Welcome to Behind the Clinic Doors, the place where we lift the lid on the weird, wonderful, funny and downright inspiring world of foot health. Ian, you've spent years quite literally helping people get back on their feet, sometimes after an injury, sometimes after years of pain. What first drew you to podiatry and then specifically surgery?
Okay, so do you want the real answer or
Yeah, yeah,
the slightly
real
more
answer.
politically correct answer? Right. Okay. So the real answer is my first ever crush when I was 13 years old, when I was at school, was a girl called Hazel. I won't say her first name, not that she'll be following me. She wanted to be a chiropodist, and my mother was a chiropodist. So my first memories are of mum working from home as a chiropodist. But Hazel had made a beeline for my mother because she wanted to be a chiropodist like my mum. And Hazel was my first ever crush. Lovely little girl. We were like youngsters together in the same swimming club. And I decided that I'd be one too. So that was really what put me on the track to do feet. It was Hazel rather than my mum, but latterly my mum.
What made you progress into the surgery side of things?
So when we were at so I trained at Salford. So I was lucky enough to get a few interviews in East Anglia. There were quite a few jobs going in 1988 when I qualified. Bloody hell. 40 years ago I started my training gainer. So 1985 I started. As you rightly point out, I'm very old. So 1988 I was looking to spread my wings, move from the northwest, and lots of jobs going in East Anglia. So I had a little look at different departments and was interviewed during the week. They were doing surgery training for Ipswich Trust as kind of was, and they were literally running their own in-house pod surgery training. It wasn't called that then, and I was just really fortuitous that I literally sat with these guys at lunchtime. So names like Gene Mooney, who you'll have come across, the great Gene Mooney, who's still going great guns now, who was part of the first cohort. And I was lucky enough to sit with these guys during lunch. It was an all-day interview, and I went, "Wow, surgery." We'd sort of heard about it really, but they really, kind of lit a fire. And I just kind of went back to the Northwest and went, "This is what I need to do when I qualify." So I qualified in the summer, was lucky enough to get a job. Started on the 1st of August 1988. Thank you, Sean McLaughlin, my first boss. Took a bit of a punt on me. And then after waiting my turn, after a few years, they started to train me in surgery because we had a kind of an in-house training system for some people external to our trust, or well, it was what was it back then? It would be a unit. So I'm going back way before trust. It was a what would it be? The community wing as it was then, and sort of waiting my turn, and they started training me in 1992 in surgery.
In surgery, wow. How would you say that podiatry or even surgery is compared to the today? So how did it look like then to today?
So if I say I qualified as a chiropodist, so 3 year chiropody diploma, it's obviously a degree now. The course I think is broadly similar to the degree now in terms of content. The
Hmm.
biggest difference is, and we actually had some very good teaching at Salford back in the day. I look back and I'm not sure I quite appreciated how good some of the teaching was. Looking back, it's only when you become a teacher and a mentee you realise some of the teaching that you had was really good. So I'll name check people like Rob Kidd, fabulous at anatomy, Pete Bowden, biomechanics, Frank McCourt, sadly died, and even some of the more routine chiropody was actually taught to a very good standard. But it was chiropody. It was a little bit cut and come again. It was a bit routine practice. You weren't really taught to cure a patient. What the emphasis wasn't, this is a problem, let's see how I can fix it and cure the patient to
Yeah.
move on. And that was really changed from, ironically, from Northampton. So the Northampton school was set up 30 some years ago now, and the first cohort of lecturers at Northampton completely changed the profession. So you had people like actually Rob Kidd, my old anatomy lecturer, had moved to set up Northampton with people like Marcel Pook, who was the guy that did the funding for it, Steve Avell, David Tollifield, Linda Merriman, and a really excellent cohort of lecturers. And what they set was something called the National Record Card, which was basically saying, let's do a proper medical assessment. Let's look at the problem. Let's really identify it. Let's see what we can do to get the patient cured. Now, no, I'm not saying within the world of routine, excuse the term, chiropody podiatry, that you'll always get many patients cured, but it really looked at how we can get the patients better. What can we do rather than couldn't come again and have patients on for years and do more of a kind of a basic chiropody treatment. So although we were actually taught a lot of medicine physiology at Salford, I think there's more of an emphasis now on needing to know it. So certainly when I'm involved with students now, and I've got students on placement with me at the moment, I expect them to know a lot more. We were taught it, but weren't expected to remember it. Now I tell guys, like, anatomy is not just to get through an anatomy exam. You need to know your anatomy so you can diagnose. You need to know your pharmacology. You need to know your phys, and you can work in routine practice and not need all those things. I don't want to be politically incorrect. You can kind of coast on a fairly basic level of knowledge.
Yeah.
But I'm the profession is much more medically focused now. And in
Than it
fact, some
was.
people think we are part of medicine. We're not. We're part of healthcare. But yeah, does that answer your question, madam?
Really does answer the question, actually. That's really interesting. How many procedures roughly do you think you've carried out in total?
So on my log, I've got 16,500 procedures. If you gave me 2 minutes, I'd give you an exact number. So on the same day, November a year ago, I reached my 4,000th hammer toe, my 3,000th bunion on the same day, which was quite poetic. Now that's for my log. And all surgeons log their cases, Gaynor. Now I log mine by an order of three. So ones that I've observed, so ones I initially did my observation, so in 1992, so I can tell you all the procedures I observed before I started to assist and then before I did. So level A, B, and C. Observe, assist, and lead. So my log of those 16,500 procedures is broken down by those three levels, but also then by 5 levels of depth, if you will. Digital, first ray, soft tissue, other osseous, rear foot, ankle, and trauma. So, it breaks that down. I use a spreadsheet, which is 33 years old, that spreadsheet, since I started doing it.
You keep that
Yeah,
still.
yeah.
It's
And and,
brilliant.
and and I think nearly all surgeons do. And we need to be able to say, because we get quite a lot of pushback on us as surgeons and say, well, how many of these procedures have you done? So I can say, well, I've done this many of this procedure, but we also need to demonstrate a learning process. If I want to do, for instance, a new procedure, then I would want to say, well, I've observed it being done, and that might be watching another surgeon do it, or it might be a
Yeah.
cadaveric course. So some of the surgical procedures I learned on cadavers first. And then I was assisted or trained in it. So I was working with another surgeon who guided me through. And then at the point you become ABC, you then lead it. So for all the procedures I've done, I can show a progression. Excuse me, because in the olden days, if I think about some of my mentors, they'd been given a fairly basic training in surgery and then kind of learnt out in the field, which back in the day was how, and I'm not just saying podiatric surgery, but some of my old orthopedic friends, they were sort of taught the basics and then applied principles. But it's much more now templated. You're expected to show a progression. You can't just kind of say, "Oh, I quite fancy doing something new." Those days are thankfully long gone.
Yeah. Are there any of those cases that are particularly memorable to you?
Yeah, the ones that went badly and the ones that went really well. So one of the things that I keep is what's called an M&M log, and it stands for mobility and mortality. And this is something that the orthopedic surgeons, because for 8 years I was honorary part of an orthopedic team, and every month they would have an M&M meeting. So all the consultants, all the registrars, all the SHOs, and you were required to present any cases that had not gone well. And it was a case to demonstrate what went wrong with the case. And you would then get feedback from your elders and betters, and that feedback would not always be very kind if you had really dropped the ball. So it was learning for you, but it was also to show if cases hadn't gone well, learning for the wider what we in orthopedics we call it firms. You'd have a consultant registrar and a house officer back in the olden days. And it's that classic Oscar Wilde line gainer of a man that learns from his own mistakes is clever, but a man that learns from other people's is a genius. So if I've done a case and it's really gone terribly wrong, I present what's not gone well for me so that ideally other people won't do that. So although I'm in full-time private practice now independent, I keep my own M&M log. So any case that I'm not happy with, I keep a log on. So I've got a patient at the moment who's just come from an infection, got two patients on the go with non-unions. I've got one recurrent bunion. So I keep a log of my active cases that I'm worried about, and then that forms part of my reflective practice and appraisal. So every year we are appraised by another surgeon, and I will show these are the cases that I struggle with this year. And it's all part of clinical governance as well, particularly in private practice where we're independent. You need to show that you're actually part of a wider team. So we have a regional group. We meet virtually every 3 months, and then, as I say, appraisal every year where we go through those cases. And you've got to do that, whether you're working in isolation, particularly, or even as a part of a team.
Yeah.
You need to show that you're keeping current and you're not just a lone practitioner. There've been some
Yeah.
big headline cases in medicine over the last few years of independent surgeons who've really gone off and done some really bad stuff without the oversight. Looking at things like the Patterson inquiry, and there's been a few bad
There
cases.
has, yeah, there has. During your years leading podiatric surgery in Northamptonshire Trust, what are you most proud of in terms of how the service has evolved?
So I'm most proud of the team. When I took the service over in 2001, it was me. It was 2 or 3 days of a senior one podiatrist and a half-time healthcare assistant. So literally 3 people and a little bit of secretarial support. When I left and went into full-time private practice and handed over the service to my successor, there were 1.5 full-time consultants, full-time medical secretary, a couple of nurses, and a team of staff pods. So the biggest thing that I'm proud of is actually building the team up and passing it on, because it's all about the team. And within that, taking a number of trainees through from trainee to registrar to consultant. So three of my 5 students that I have, 3 of them made it to consultant. And that's probably the best thing in terms of legacy. You've paid it forward. I'm lucky enough to have a certain skill set. Much of it is, majority of it really is that people have taught me how to do the surgery, how to behave, how to practice. And so you've got to pass that on. And I have very little time for consultants that don't teach, that don't train the next generation, because it's a discourtesy to the profession.
What's some of the biggest changes you've seen since you started operating?
Scope of practice. When I started off, all we literally did was simple hammer toe arthroplasty procedures and lumps and bumps. Bear in mind, my particular unit that I trained with at the time was fairly limited in scope. So now that we have a range of surgery, so I've seen patients today who have done bunions, amputations on, flat foot surgery, amount of Achilles surgery. So the scope of practice is so much bigger, and the range of hardware and equipment we use has grown a lot in that time. So it's a much fuller practice than I was originally taught back in Ipswich in the day, and that was my old tutor was fairly limited. I'm saying this because he passed away a year or two ago, so I'm not speaking ill of the dead, but he was fairly limited in skill set and ability. He wasn't actually a very good tutor, I'm sorry to say. So my initial training was relatively basic, but then I had other people that really helped me moving on to get my skill set up. So it's because of mentors like that
Yeah.
who allowed me to kind of develop my skill set. So there's a few people out there I'll be forever grateful to have took me under their wing. Then I try and do the same with the next generation.
With the next generation, has equipment changed in that way as well? Because the
Yeah. I mean, I
world's going
remember.
more electronic, isn't it, in AI? So has equipment within your surgery changed, do you think?
So back when I started training, the fixation was fairly basic. So we have a much broader range of fixation now in terms of what was pins and simple screws is now complex screws, plates, and some really interesting hardware. So the fixation material is much better. That's probably been the biggest change. But it's still a lot of it is knife, fork, and spoon and a small circular saw. Fixation is probably been the biggest change. But then there's been huge advancements in terms of soft tissue anchoring and techniques like screed bridges for Achilles repairs. MIS surgery is coming on stream as well, which is of some utility for certain procedures. So, but it's broadly the same. But there's probably been the biggest advancement in fixation because the foot and ankle kit used to be just mini orthopedic, and now there's a lot of foot specific instrumentation that is designed for the foot bones as opposed to just little knee bones and little hip
Yeah.
bones and little hand bones.
Do you think over the years that patients' understandings and their expectations have evolved towards surgery,
No, not
changed?
even slightly. No, not even slightly.
Really?
No, not even slightly. People people still think they know best. People still ignore advice that I give, as happens to all of the surgeons. People are spending time on Dr. Google and taking advice from their friends as to what they should have, and pretty much paddle their own canoe. I've had a bad year actually for non-concordant patients who've not followed the surgical plan and then have developed problems because they've not kept off the foot, they've changed the dressing, they've not worn the post-op shoes. So you've got to keep that message going on that it's a team approach. Concordance rather than compliance. Compliance was you do as I say, old style thinking. Concordance is we need to agree what surgery we're going to do and what the post-op recovery is going to be, which might be as simple as keep off it, don't take the dressing off, don't change your post-op shoe, and I know it's a kind of a constant battle, really. Much as I love my patients, you can never take your eye off the ball.
No, no, you're right. So with the developments that we've talked about with technology, imaging, and anesthetics as well, um, anesthesia, sorry. Um,
Yeah,
how, as
go
minimally invasive surgery, how are these advances impacted patients' outcome?
on. So minimally invasive surgery, I think, is fabulous for something like if you're having a cholecystectomy or like a gallbladder procedure. So back in the
Mhm.
old days, you'd have a big 12-inch scar, and that was what everybody would have back in the Sir Lancelot Spratt days. Now you wouldn't get a general surgeon not doing that under MIS, or basically, with minimally invasive surgery. Now, for the foot's not really big. You can't really insufflate an ankle with CO2 to really pop a foot up. And so MIS, the origins of MIS, which was quite interesting really, was in America, you would do your training, because this came from America as all these things do. You do your training, you would get a residency, and you go off and be a surgeon. Now, not everybody got a residency in a hospital to learn how to do surgery. So MIS was basically done, keyhole surgery, in a clinic rather than a theatre by surgeons who couldn't get trained in a hospital. So you had the situation of less well-trained surgeons doing what effectively is more difficult surgery because you're doing it blind. And of course, you can imagine the problems that ensued. So it had a really bad rep for 40, 50 years. Now we're on basically third generation MIS now. So now you've got surgeons who are proper, what I would call open trained surgeons, who are now coming back to doing MIS. So you've got guys already with the skill set who are now doing that more difficult surgery. And there's a bit less soft tissue trauma, but not that much. So by and large, there are one or two guys who I think do really good MIS surgery. But if I'm thinking about MIS bunion, it's still an osteotomy, it's still a break. Unfortunately, what you have is two problems. You've got patients that think because it's MIS, it's not surgery, and they can do what they want the day after surgery. And then you've got some clinicians and surgeons who almost promulgate that view that it's kind of like have surgery during your lunchtime and you'll be back to work tomorrow. It's still surgery. If it's a bunion, it's still an osteotomy. And most of us look at it and think, I just don't know that the benefits outweigh the risk. I've did the course a couple of years ago for MIS bunions. I do some MIS techniques. But if it was my bunion, I'd want somebody to open it up, see what the problem is, fix it. Longer wound, more soft tissue trauma. Um, but I'm still kind of an open guy as an open surgery. But there's one or two, pod surgeons in the UK, uh, Tony Wilkinson, Kay's engineer, who do a lot of MS bunion surgery, and I'm thinking they're getting good results. But when you've looked at the meta-analyses, basically the outcomes are pretty equivalent, really.
Okay. With all the surgery that you've done, what is the most common?
By procedure, hammer toe. So 4,000 procedures this time last year. So that must be heck about 4,500 now, because obviously people have multiple toes. But the referral I get most is for bunions. So that's probably the biggest referral case for me. But obviously you tend to do one or maybe two bunions, but you might do four hammer toes. So by number it's hammer toes, but by referral it's bunions gainer.
Okay. Is there a condition that's misunderstood or gets left too long before somebody seeks help?
Oh, everyone, yeah, everyone's misunderstood. You can leave a bunion for too long. I had so interestingly, I had a case this morning. So referred from a podiatrist with 20 years experience, who'd referred in for a bunion for me to do bunion surgery on, and the patient actually had hallux rigidus, and so it's a completely different paradigm in terms of what I can do for that patient, and so I need to have a conversation with that pod and say, your diagnosis uh, was wrong, and to me it was a fairly obvious arthritic joint, but to a pod of some experience, perhaps not so. So I think there's quite a disconnect really between podiatrists and pod surgery in terms of, we're not, in some ways we're not all kind of part of the same profession. We are, and yet we're not. And just I see variable levels of skill and experience. Right, I'm going to be an arse now, Gainer. I spend a lot of time on Facebook looking at people posting, and I spend some time with some really good podiatrists who do good referrals, but I also see a lot of the profession out there that don't have the kind of skill and knowledge set that I would like us to have when many of us shout pods fix feet, see your podiatrist first, which is fine unless you've got something not out of the ordinary. So for instance,
Yeah.
if you've got a pod of 20 years experience that can't tell the difference between hallux limitus and hallux rigidus, I've probably got podiatrists throwing things at the screen now. Please tell me nobody will ever look at this video, because that's not going to help my popularity contest. But that's
You know
okay.
they are.
That's okay. One of the things I try and do is I do a lot of education, love it, enjoy it, and that's great. The trouble with being a know-it-all like I am, and I do not know it all, but I know I come across as a know-it-all, is that I will challenge people if I see people are, in my humble opinion, incorrect. So I spend a lot of time on Facebook saying, sorry, you're wrong. And of course that's, not very popular, but if I see somebody put a post up and they're wrong, then I'll jump in and say, actually, no, that's not correct. Then you can have a nice nuance when you do it face to face, but obviously the written word, you can just come across as a bit arsey. But a lie unchallenged becomes a truth. So I'm relatively happy to say, no, that's not quite correct. So I'm sure
Yeah.
in sectors people think I'm a complete arse. And I'm mostly okay with that, because you've got to call stuff out and say, no, that's not correct.
Yeah, yeah, and by both calling that out, you give somebody a chance to um, have their say as well, and then you can have that conversation whether why they feel it's correct and or not. And
Sometimes,
so yeah,
sometimes I
I,
um so I love all the socials, and I was on good old Instagram a few weeks ago, and there was two new qualified FHPs, and I'd seen them, and I'd kind of tag everybody in, and they both put down as like foot specialist. So I'd messaged them both privately and said, if you're a newly qualified FHP, are you really a foot specialist?
yeah.
Now, one of them's completely ignored me, and the other one, we had a conversation. She went, you know what? That's a really fair point. Compared to what a
Was
specialist
that
is not,
me?
no, it wasn't. And I don't consider myself a specialist. Did we have a conversation online a little while ago? Oh God,
Yeah,
that was you.
it
Because
was.
I can't help it, can I? I
It
am
was.
just such.
But I can't help it. I'll have my say as well. But
Yeah,
we
no,
had
but
a
that's
lovely
okay.
conversation actually, and we both see each other's point.
Oh, that was you,
We
wasn't it?
did.
Oh,
It was
there
me.
you, well, there you go. So
The outcome was good.
because we had a really good conversation about it, but I would argue. I mean, I don't call myself a specialist. because it's not a term that I use myself. I mean, I possibly am, sort of, maybe. But I think you've got to kind of walk the walk. And there's obviously social
Yeah,
media, you've
yeah.
kind of
It's
got
in
to
the
big yourself
context,
up.
isn't it, of where you're using that
Yeah, yeah,
specialist,
yeah,
really.
yeah.
And by us having that conversation, we got to the context of what I
That's
was
so funny,
saying.
Gator. I
Yeah,
didn't realize that
that's
was
me.
you. Is
It's
that
all
is that
right.
because you don't have a picture of yourself as your avatar? Because
No, I
I didn't
haven't got an
realize it was you.
avatar.
Because you've got a background. Obviously, you've got all the skills, haven't you? Because I remember we had that conversation now.
Yeah, 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 and
Oh,
that's
that's
that
so
was
funny.
it. So I think I'd posted something. Was it a wound or something? I'm not
Yeah,
quite sure. I suppose something, and then I thought, well, I have got a background, but we had that conversation, so I was confident in doing what I was doing.
yeah, yeah, yeah.
But if we didn't have that conversation, you would never have known that.
No, no, no.
And
But when I
it,
see these things, I can't not help but challenge. What I challenge is maybe too strong a word. Highlight, because I just don't think, with everybody necessarily that's accurate. Now, there's a hypocrisy there in that I am a consultant podiatric surgeon.
yeah,
Now,
you're all the way up here, Ian.
well, I'm not. I'm not compared to what orthopedic surgeons think, but
No.
to orthopedic surgeons, we are consultants when, for all the years of medicine, you have to be a senior doctor to make consultants. So obviously we're not very, the situation is well marked out. The turf rivalry between consultant orthopedic surgeons and consultant podiatric surgeons. So our consultancy title is not super popular, but now we have consultant nurses, physios, etc. And surgeon, the orthopedic community don't like the fact that we use the title surgeon. They would much rather that we said we were consultant podiatrists. In fact, just within the last few weeks, the Australian podiatric surgeons have been required to drop podiatric surgeons a title, and they're now surgical podiatrists. So, which is interesting, really, because you think about the grammar of it. So, if you're a surgeon doing surgery, so it's not surgical podiatry because you're not doing podiatry, you're doing surgery as a podiatrist. So, the situation in Australia is also quite a kind of a turf war, really. So I say that as a hypocrisy, having a title that is quite anathema to our medical surgical colleagues.
Yeah.
So you know I'm a hypocrite. However, I can't help myself.
Going back to obviously surgery, uh, and any of the patients or general public listening here, what
Yeah,
can they do to help themselves or ensure a smooth recovery from surgery?
rest, rest, and do what your surgeon says.
I would say.
So I'm a member of I like to lurk on various Facebook groups. So great experience for getting into the psyche of a patient. And I cannot get over how many, I'm on one for hallux rigidus, Mort's neuroma bunnies. It's brilliant to be a lurker on these groups. And, people will kind of go, I've just had foot surgery, or I want what do you think, on another group of patients? And occasionally I'll
In
just
that
kind of have
group.
to kind of jump in and say, why not ask a surgeon what the advice is, rather than asking another person of the lay public who's maybe had N=1, maybe they've had a bunion done, and now they suddenly think they're an expert in bunion surgery.
Yeah.
So the advice is always listen to your surgeon. And it happened. Buddy of mine, one of my fishing buddies, hurt his leg earlier in the week, and he put a picture of his leg up, and it basically said, "Oh, what shall I do for this?" So I went in and said, whatever you say, Steve, or whatever other people say, we can't tell without seeing you, assessing you, scanning you, and then giving you a plan. So if people come on and see a picture of your leg and give you advice, might be well-meaning, but you need to present a case. And it's one of the things I see again on Facebook, which I love. Pods will put a picture up, or FX will put a picture up and go, what do we do with this? And it's just like, that is not how to present a case. If that was my student in clinic, they'd get slapped around the back of the legs with a 12-inch ruler if I was allowed to do it still. Just to say that is not how you present a case. Be professional. Don't kind of go, what do I do with this?
No, I
It's
need a
not
background.
shoddy, 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 shoddy. And again, gets me huge amounts of likes and popularity by being an arse. But I'm okay with that because
Are there
it's
any?
not right.
No, it's not. It's not. And yeah, there needs to be a lot of context really to
Yeah,
that.
yeah, because
There's
otherwise
a
you're giving
lot.
advice with half a picture, and then you could give somebody, really bad advice, seriously.
Yeah, and sometimes the angle of a picture doesn't show a
Yeah,
true
yeah,
story.
yeah.
So there's a
You
lot
know,
more.
is
Even
it
a
a,
picture.
is it a bruise or is it a melanoma that needs a 2-week
Yeah,
referral?
yeah,
So.
yeah. Are there any myths about foot surgery that you'd like to clear up?
Oh my crumbs. Yeah. So I still get patients come through and having been told by their podiatrist, oh, bunion surgery doesn't work, or bunion surgery is really painful. It can be, but we do a lot with pain control. So there are lots. And certainly as I'm actually going to start teaching, I'm going to do a little bit of a module for one of the universities in a few weeks' time. So I'm actually going to give them an overview of podiatric surgery. So in terms of if you've got a patient that presents with Morse neuroma, hammer toe, bunion, hallux ridges, etc., this is the situation. This is what surgery can do for your patient, so that in the future, as best as I can do it within the time available. You get a patient that comes through with, say, a hammer toe. Your patient's going to say, "What do you think about surgery?" I would like every podiatrist to be in a position to say, "This is the condition. These are the surgical options that your surgeon might advise you on. That's a good idea or not," rather than saying, "Oh, don't have surgery, it doesn't work."
Yeah.
And surgery works for a lot of conditions. We get complications, we get failures. But ultimately, think about referring for a surgical opinion. We'll tell you whether we think it's right for that patient or not. So I think
Yeah.
there's still a few of my colleagues who are still a little bit, if not pro-surgery, some of them even anti-surgery. And I hear that every couple of weeks. Oh, my podiatrist said not to have this, that, and the other.
You've mentored and led teams for many years. What qualities do you think make a great podiatric surgeon?
I can only say that looking at other people because I wouldn't consider myself a great podiatric surgeon. I would genuinely consider myself slightly above average, and that's it. Where I think I'm maybe slightly more than above average is in terms of motivation. I've always been fairly full on, bit of the old ADHD, which I'm okay with. So I've worked hard because I'm very average. So I have to work hard to kind of get up to the level of people who are more skilled, more capable, cleverer than me. The sorts of qualities that I'd like in a good podiatrist, obviously, it's good technical skills. That's kind of the easy bit, really. And if you think about surgery, we break down into 3 phases again. So it's preoperative assessment, surgery, and post-op management. So you've got to get the right plan, right diagnosis, operate well, manage that post-op complications. You've got to teach all of that as a kind of like this we call the perioperative period. So there are some softer skills around that in terms of patient management, really caring about your patient and putting them first and wanting to do a good job. So what I hope I've tried to do with my guys is really teach them to be patient advocates, to really care about the patient and to see them as a person attached to a foot, not a foot in need of surgery. So the technical bit is kind of the easy bit. And I think if I do have a skill, I think it's, managing that kind of that patient communication and environment. And I still love it, and I get some nice feedback from patients, which is, makes up for my average surgical skill set, which is nice, and my awful dad jokes that I do. So that's what I try and inspire in surgeons. But it's also about being a leader. So I'm lucky enough to have some time in the army in a previous life. Was really taught about leadership principles, and it's about standing up, it's about integrity, it's about making those difficult decisions. Sometimes, being the bad guy in a team, because sometimes the right thing to do is the right thing to do. In fact, always the right thing to do is the right thing to do, even if it's not very popular. And having some courage as well. So about, being somebody that you can look up to and go, yeah, that's the way to be, which is not always a popularity contest. And I can remember a few awkward conversations in my team. I remember one a few years ago, and literally about a year ago, one of my ex-team members came up to me and said, "Right, I see why you did what you did a few years back. I didn't get it at the time, but you were right." And it took him a few years to kind of work that through and go, "Huh." But I was over a particular issue it was a skill mix issue actually within the team. It went down like a French kiss from your grandmother, I can tell you, but it was the right thing to do. And it just took a while for people to realise that the right thing to do was the right thing to do. So yeah, it's leadership really, leadership and good skills, but caring for your team. Now, again, this was something I was taught in my army days, is you've really got to worry about your team. They're your guys. Yes, you've got your patients, and this is the kind of the Richard Branson school of leadership. You know, everybody says, "Oh, customer is king." No, you look after your team. You have a well-trained, caring, motivated team, and they will look after the patients.
Yeah,
You
that's
know, so
important.
I would worry about the team, and you wake up in the morning, think, how the team going to be? So if they really matter to you, then they will provide the care for the patient. Sorry, I'm losing my voice a little bit, but just getting over the lurg, Gaynor.
There's been loads of that going about. Now that you've
Excuse me.
transitioned from the NHS to private practice, how do you see the landscape of podiatric surgery evolving in the UK?
We're struggling actually because we're not growing. The orthopedic foot and ankle profession is growing and getting stronger all the time, whereas years ago it's a really small element. So they're getting bigger and better, which is good for the patient. Pod surgery as a profession is relatively stagnant. We're not growing, very much at all. In fact, we've lost quite a few units over the last few years. So there's quite a turf war between the two groups, and I could speak about that offline. It's very much a matter of public record. Sadly, I get it because we've moved into a medical surgical field as jumped up chiropodists, as I've been called many times. So I get it. So I'm not sure how the profession will grow because we're not funded to really grow. That's probably the biggest issue. We don't have the funding behind us to kind of grow and get better. It's a shame. It's a tragedy because we've got a lot to offer. So I'm not sure how bright and rosy the future is for pod surgery. However, let's not be tribal. What matters more is that we have systems that provide good surgical care for the
Yeah,
patients. So I should not be tribal and say if the best thing for the patient is a really effective foot and ankle orthopedic service, then is that such a bad thing? I mean, I am a bit tribal, but we should really care more about systems and patients.
systems, yeah, as a whole, really, as well. So, looking back over your career, what would you say was what that you're most proud of, or what legacy would you like to leave with the profession or in the profession, should I
Probably
say?
my teaching, although I've really loved helping patients, and that continues to be a joy when patients get a good result. It's really the legacy of team, so that people I've trained who've moved on, and there are three of my trainees who've made consultant, but a number of the other consultants out there who were podiatry students who spent time with me who've gone into surgery because of me. So that's um, so one of my mentors, I mentioned Rob Kidd. Rob Kidd was one of my lecturers at Salford back in the day. He moved out to Australia about 30 years ago now, and was the first PhD pod in Australia. And I went to visit him a few years ago, and he had lots of his kind of old students come around for a barbecue one day, and some were podiatrists, some were physios, some were were what would it be, medics really, because he taught anatomy to different groups. And he was the first person to really show me what legacy was all about in terms of people you've inspired to move on. And Rob and I continue to keep in touch. And I've had that same experience where I've had a group of my guys that are at a certain position
Yeah,
in some very small way because of the opportunities and the facilitation I've given them. I think for a lot of the time I've probably just kept them back if I'm honest. But yeah, it's seeing your prodigies flourish. That's the best thing.
do you still get the same sense of satisfaction when you see a
Every day.
patient walk? I was going to say, after
Every day.
all of the surgery that you've performed, do you still get that same sense of
Every day.
satisfaction as if you've done the
Every day.
first?
Because
Wow.
every case can go completely pear-shaped, and you can have a very unhappy patient, very bad outcome, and every day you're kind of squeaking a little bit really. And as it should be, you should have that sense of fear and concern and worry and passion for it, and yeah, love it. Yeah, love it as much now, if not more than ever. Hence, I still do 60 hours a week, and in terms of a lot of that is education. I spent all
That's
of Sunday writing PowerPoints for Galway, because I'm doing this pod surgery day for Galway in 2 weeks' time, and these PowerPoints have not seen the light of day for 7 years. So I spent all of Sunday updating them. Being a bit nerdy but loving it.
If they, sorry, Ian.
That's
If
my excuse my email.
if there's a podiatrist interested in going into surgery, what advice would you give them?
Ha. I'm going to turn my email off so it stops pinging. Right, oh, sorry. Where'd you go? Was that me or you? That was you.
You.
Sorry, edit that bit out so I don't look like an idiot. So I've got two of my oh, excuse me. Two of my current students who've just started on the master's program, which is brilliant to see. What I would say is that the path to podiatric surgery is tough. So you've done your 3-year degree, you've then got 2 masters to do, master's theory, master's surgery, and another 3 years as a registrar. So you've got another 7, 8, 9 years ahead of you. So it's tough, and there are various bottlenecks on that route. Difficult to get into the. No, it's easy to get on the master's program, but it's difficult to graduate and then get a surgical training slot. So really, to be prepared that it's not going to be easy. And I think if you get 20 people start on a particular cohort, there'll probably be only 2 or 3 make it through. So just to be realistic and say it's really tough. However, what we have now is we have different step-off points. So when I trained, you passed or you failed, and the qualifications you got had no academic reciprocity. Whereas now you've got master's programs. So if you do a master's in pod surgery theory and you don't get any further than that, you've still got a master's. It's still really good training. And then there are roles within surgery as staff podiatrist doing anaesthetics, and there are kind of sideways routes. So I would definitely promote it. I would just be realistic and say it's really tough, and you probably won't make it unless you spend the next 5 to 10 years working 50, 60 hours a week and mean it.
You've got to be dedicated.
Yeah. And lucky as well. Lucky enough to get a trainee gig, because I know some really good potential trainees out there who just haven't managed to get a trainee slot.
That's it, gosh.
Who would be way better than me given half an opportunity. Just don't tell them.
Okay, thank you, Ian. It's been such a pleasure talking with you. Your experience and insights have really shone a light on just how much expertise and dedication goes into podiatric surgery, and how much with the profession or from the profession has evolved thanks to people like you, actually.
I've
So
done
thank you so
nothing
much.
for the profession, but thank you.
Do you know what? No, actually, talking to you, I really do think you have.
I've done a
You
little
are,
bit for the people around me.
yeah.
There's people out there who I still look up to. People like David Tollerfield, Tim Kilmartin. These are people who are aspirational to me. Thank you, Gay. That's very sweet.
No,
I
I think
think
you have your
it's just all
CPD.
doing our bit. Where I perhaps had an influence is just one of the things that's lovely. Every single day, I get pods email me for help with a case. And very often it's pods I don't know, and they just so they must think I'm approachable or think I know something, which either way is very flattering, really.
That's
And it's
good.
just really nice to be asked for, opinions and stuff. And of course, I normally say, don't bother me unless you're going to pay me for my advice, because no, I'm joking. But that's the bit that I've probably enjoyed most over the last few years. Still love the patient contact. But I kind of banging the drum for what am I banging the drum on? Banging the drum on injection therapy, which I think I've certainly influenced most of the people who inject in the country have trained under me, in podiatry certainly. Working hard with my good friend and buddy Belinda Longus, we're really kind of looking to develop skin and nail incision and nail surgery skills. I do quite a bit with obviously anaesthetics, trying to upskill people. So yeah, I enjoy that.
No, that's brilliant. For anybody or any of the listeners wanting to learn more about Ian Reilly's work, I'll include the link on the show notes. For any of the practitioners listening, Ian also runs a CPD Facebook group, but a CPD group actually. But you also run a Facebook and Instagram, don't you? It's Footnotes.
So yeah,
Have
the
I got that
footnotes have
right?
just started up. So that's with a couple of buddies of mine, Mike Stevenson from Glasgow. He's
Hmm.
kind of behind, kind of running it. And then John's an ex-pod ICU doctor, so we're starting to do some CPD stuff together. And then I do kind of various different courses. So the best place to find would be my Facebook business page where I kind of put my courses up, and I probably need to do a better job of promoting the stuff I do, but I don't like to look too needy because I sometimes think I'm a
No.
bit overexposed. But then I get criticised by pods saying, "Oh, where do you advertise your courses? Because I want to do your Veruca course with Belinda or your skin course." Or I've been doing a lot with ankle blocks this year, running small group workshops so people can come. I've been running that with a pod friend of mine down in London, where she gets patients in, and then the podiatrist will actually come and actually do an ankle block. And we had a girl in a few weeks ago, never done an ankle block in 20 years, never done an anaesthetic in 20 years. So we do a bit of theory, a bit of practice, and they go away with a skill set. So yeah, it's just
No, I think it's worth advertising and people to look for you because it's CPD, it's learning.
yeah.
It's all beneficial. Knowledge is power. So. Thanks again, Ian. Thank
Thanks,
you.
Kate. Really nice to meet, and